Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections.
Thank you so much for having me.
Today, we are taking a deep dive into our source material to track a microscopic shapeshifter, an ancient assassin that basically hides in plain sight, claims hundreds of thousands of lives every single year, and is currently locked in a really high-stakes evolutionary arms race with modern medicine. We're talking about Streptococcus pneumoniae.
Yeah, it is a pathogen that truly tests the limits of our scientific ingenuity. I mean, picture the year 1881. The legendary scientist Louis Pasteur is peering through his microscope in his lab, and he becomes the very first person to successfully isolate this exact bacterium.
Wow, 1881.
Exactly. It was this monumental discovery at the time. But, you know, the reality of how this organism operates today is it's profoundly unsettling.
It really is, because right now, as you listen to this very bug is silently colonizing the throats of up to 50% of all healthy preschool-aged children and about 10% of healthy adults. It is just sitting there, waiting. And the global stakes of that silent waiting game are staggering.
They absolutely are.
Like, you look at the sources, without the vaccines we've developed, this single pathogen would cost the global health system $13.7 billion every single year. But the human cost is the true tragedy here. Globally, it causes over 300,000 deaths annually in children under 5.
Which forces us to ask, you know, how does a bug go from being just a quiet microscopic neighbor in your throat to a lethal threat?
Right. How does it make that jump?
To understand that, we have to look at how it's built. Streptococcus pneumoniae, or often we just call it pneumococcus, is a gram-positive, alpha-hemolytic, facultative anaerobic bacterium, and it is entirely specific to humans.
Okay, let's unpack this, because I know facultative anaerobe sounds like a mouthful, but it gives the bug this terrifying versatility, right?
It does, yeah. It means it's just as happy sitting in the breezy, oxygen-rich environment of your nasal passages as it is surviving in the oxygen-starved depths of infected lung tissue. It adapts instantly to whatever environment it finds itself in.
Which is wild. But its real weapon is its exterior. I mean, I've seen it described in the source material as armor, but it functions much more like a custom-made cloaking device.
That is the perfect way to look at it. In medical terms, we call this its capsular polysaccharide. It's basically a really complex sugar capsule that surrounds the bacteria.
Like a thick shell.
Exactly. Our immune system relies on these white blood cells called phagocytes to swallow up and destroy invaders. But these phagocytes need to be able to see and grab onto the proteins on the surface of the bacteria.
And the cloak stops that.
Right. This thick sugar cloak completely covers those proteins. It's like a greasy coating. The bacteria essentially becomes invisible to our primary defenders. They literally just slip right off.
So it's an invisible threat. And it doesn't just have one standard issue cloak, does it?
Not at all. There are over 100 different variations of this sugar cloak, which we call serotypes. The bacteria can essentially, change its disguise on the fly.
Over 100? That's insane.
It is. But nature is highly efficient. Out of those 100-plus serotypes, only about 20 to 25 of them are responsible for nearly 90% of all severe human infections.
Okay, so if it's this perfectly evolved invisible threat, when did we actually figure out how to fight back? Because we obviously didn't just sit there and let it win.
If we connect this to the bigger picture, the timeline of our modern medical defenses really kicks off in the United States in 1977. That is when we introduced the first polysaccharide vaccine, known as PPSV14.
And the 14 refers to the number of cloaks it targeted, right?
Correct. It targeted 14 of the most common cloak types. Then, by 1983, that was upgraded to PPSV23, targeting 23 types.
But there was a massive physiological flaw with those early vaccines. Like, they worked relatively well for adults, but they completely failed to protect the most vulnerable targets, which are infants and toddlers.
Yeah, it was a huge problem. And the reason why comes down to how an infant's immune system actually matures. Children under 2 simply do not have the sophisticated immune architecture required to recognize a pure sugar molecule and build long-term memory from it.
So the vaccine was just doing nothing.
Essentially, yes. The vaccine was invisible to them, just like the live bacteria. But that failure pushed the science forward, and the year 2000 marked a massive revolution. We introduced the first pneumococcal conjugate vaccine, or PCV7.
Because scientists figured out how to chemically link or conjugate that invisible sugar cloak to a highly visible carrier protein.
Exactly. like strapping a bright red flag to an invisible thief. Suddenly, the infant immune system could recognize the threat, remember it, and actually fight it.
That's brilliant.
It changed everything. And this didn't just protect the vaccinated babies. By stopping the bacteria from colonizing the babies' throats in the first place, it drastically reduced the amount of bacteria circulating in the entire community.
Oh, wow. So it protected adults, too.
Yes. It created a massive shield of herd protection for everyone else.
Wait, that actually brings up a really critical point about how this pathogen finds its victims. We know it spreads through direct contact with respiratory secretions, saliva, mucus, coughing, sharing a cup. But earlier you mentioned that up to half of all healthy kids are carrying this in their noses and throats right now.
They are.
If that's true, why isn't every single preschool essentially a triage ward?
It's a really critical distinction, and it comes down to asymptomatic colonization versus active infection. The bacterium uses the human nasopharynx, that's the upper part of the throat behind the nose, as its natural reservoir.
Like a home base.
Right. When it is just colonizing, it's sharing nutrients and living asymptomatically. It has absolutely no biological desire to kill its host, because, well, a dead host means the bacteria dies too.
So it's an opportunist? It's just sitting in the nasopharynx like a sleeper agent, constantly probing for a weakness in our defenses. What exactly does a weakness look like to this bug? Is it just looking for a drop in the immune response or something physical?
It's actually both. Imagine a person gets a common viral infection, like influenza. The flu virus actively damages and strips away the protective epithelial lining of the respiratory tract.
Oh, man. So it opens the door.
Literally. It paves a clear road for the pneumococcus bacteria to leave the nasopharynx and invade deeper tissues. And the people most susceptible to this kind of breach fall into some very distinct categories.
Like age extremes, right?
Yeah. The immune system is essentially still learning the ropes in children aged 5 and under, and it naturally begins to wane in adults 65 and older. Those two age extremes bear the heaviest burden.
But age is just one factor. If you dive into the sources, you see that chronic diseases create incredibly specific vulnerabilities. Like, let's say you have diabetes. It isn't just a generic risk.
No, not at all.
Because chronic hyperglycemia, high blood sugar, actually impairs the function of your white blood cells. Your defenders become sluggish, making you a prime target. Or take cystic fibrosis or asthma.
Right, those are huge risk factors.
Because these conditions create thick mucus or chronic inflammation in the lungs, which acts like a physical trap where the bacteria can settle and multiply without being cleared out.
Exactly. We also see extreme risk in immunocompromised individuals, people living with HIV, patients who've had solid organ transplants, or individuals born with primary immunodeficiencies. Their baseline defenses are just already compromised.
And the sources also point out geography and environment, right?
Absolutely. The highest burden of disease falls on non-high-income countries, particularly in Southeast Asia, India, and Pakistan, where access to early medical intervention might be limited. And on a local level, high-density transmission environments like long-term care facilities or childcare centers are absolute hotspots for explosive outbreaks.
So let's say the bacteria finds that weakness. It breaches the barrier of a vulnerable person. What does that actually look like for the patient? Because the clinical spectrum of this disease ranges from disruptive to absolutely devastating.
It usually starts with the non-invasive forms, and while doctors might classify these as mild, they are highly disruptive to a patient's life.
Yeah.
We are talking about severe sinusitis and acute otitis media, which are middle ear infections.
I mean, anyone with kids knows how awful ear infections are.
Oh, absolutely. Pneumococcus is the leading cause of pediatric outpatient visits and antibiotic prescriptions in the U.S. just from ear infections alone. It causes intense pain and high fever.
But that is just the localized battle. The true danger, and where the mortality rate just skyrockets, is invasive pneumococcal disease, or IPD. This is when the bacteria crosses the threshold into the sterile areas of the body.
Exactly. If it infects the lungs, it causes bacteriemic pneumonia. The tiny air sacs in the lungs literally fill with fluid and pus. The patient's oxygen levels plummet, and every single breath becomes a desperate, painful struggle.
It's essentially drowning from the inside.
It is. And if the bacteria crosses directly into the bloodstream, that is bacteremia, which can trigger sepsis. That's a massive system-wide inflammatory response where the body's immune system essentially goes into overdrive and starts damaging its own organs.
Wait, if it breaches the bloodstream, does that mean it has a direct pathway to the brain?
Yes, and that is the most terrifying escalation.
Yeah.
Pneumococcal meningitis. The bacteria breach the blood-brain barrier and attack the meninges, which is the delicate lining of the brain and spinal cord.
And because it's happening inside the skull, it becomes a mechanical problem as much as an infectious one, right? The inflammation causes fluid to build up, but the skull obviously can't expand.
That is exactly the problem. The intracranial pressure builds rapidly. It physically crushes the brain tissue. Even with the absolute best, most immediate medical care, it is frequently fatal.
God, that's horrific.
And for those patients who do survive pneumococcal meningitis, the aftermath is brutal. They are often left with severe long-term neurological disabilities, which can include profound, irreversible hearing loss, lifelong seizure disorders, and severe cognitive delays.
So you have a patient in the hospital with a swelling brain or failing lungs. The doctors deploy the standard medical counterattack, antibiotics. We go to war with penicillin, with amoxicillin, with cephalosporins. But here is where the pathogen reveals another terrifying trick. Antimicrobial resistance, or AMR.
It is the shadow creeping over all of modern medicine. The pneumococcus bacterium is incredibly adept at a process called horizontal gene transfer.
Which means what exactly?
It means it can essentially sweep up loose DNA from its environment or swap genetic material with other nearby bacteria. They share DNA like kids' trading cards. When we bombard it with antibiotics, we inadvertently create a Darwinian nightmare.
Survival of the fittest.
Right. The susceptible bacteria die off, but the mutants that happen to have a resistance gene survive, multiply, and pass that protective gene on to the next generation.
And the numbers on this are staggering. Today, about 2 in 5 pneumococcal infections in the United States are caused by strains that are resistant to at least one clinical antibiotic. The CDC officially classifies this as a serious threat.
It's a huge problem.
Think about what that means for you as a patient. It means treatment failures. The standard drugs you rely on just don't work, leading to longer hospital stays, repeated cycles of disease, and the necessity to deploy much more expensive, highly toxic last resort antibiotics.
Which, just drives the cycle of resistance even further. If we want to starve the AMR crisis of its fuel, we cannot rely solely on treating the infection after it happens. We have to prevent the infection in the first place. Which brings us back to vaccines.
Let's really look at the underlying science of these vaccines, because the mechanics are fascinating. We talked about the two main weapons, the older PPSV polysaccharide vaccine and the newer PCV conjugate vaccine.
Right.
Think of the older PPSV like handing your immune system a simple wanted poster of the bacteria's sugar cloak. Your B cells see the poster, and they produce a quick burst of basic antibodies called IgM. But it is a T-cell independent response. Your T cells, which are basically the generals of your immune system, they never get involved.
Exactly. So the immune system never really learns from it. It doesn't establish any long-term memory.
Building on that analogy, the PCV, the conjugate vaccine, is a full combat training program. By chemically linking that sugar cloak to a carrier protein, often a harmless version of the diphtheria toxin called CRM197, it forces those T-cell generals to engage.
It triggers a process called class switching. The immune system converts those basic IgM antibodies into highly specialized, high-affinity IgG antibodies. More importantly, it creates a lifelong memory barracks. The next time the bacteria shows up, the immune system is already armed and waiting.
And we've been constantly upgrading this combat training. We started with PCV7, then expanded to 10, then 13. Now we have PCV15, PCV20, and the newly FDA-approved PCV21, which targets 21 different serotypes and covers up to 85% of the strains causing adult invasive pneumococcal disease.
But there is a really interesting twist here, medically speaking. While we are aggressively phasing out the old PPSV23 vaccine for general prevention, we haven't thrown it away. Immunologists actually rely on it as a crucial diagnostic tool.
Wait, using a vaccine to diagnose a disease? That sounds entirely counterintuitive. How does that work?
It is used specifically to detect inborn errors of immunity, or IEI. If a patient is suffering from recurrent, unusually severe infections, doctors need to know if their immune system is fundamentally broken. So they administer the pure sugar PPSV23 vaccine. 4 to 8 weeks later, they draw blood and measure the patient's antibody response. Because the pure sugar vaccine requires a very specific, mature immune pathway to generate any response at all, failing to produce antibodies against it is a giant red flag. It indicates a specific antibody deficiency or another rare primary immunodeficiency.
But the sources highlight that this diagnostic method historically had some massive flaws. Imagine you take your child to an immunologist. They run this test, and they use the old method, which relied on this incredibly rigid, fixed cutoff.
Yeah, the 1.3 rule.
Right. The old rule was, If your antibody concentration was above 1.3 milligrams per liter, you were considered normal. If you were below it, you were told your immune system was permanently defective.
And that static 1.3 cutoff was an absolute disaster. It was based on outdated expert consensus, not robust clinical data. Because of that hard pass-fail line, between 20 and 60% of completely healthy people were being misdiagnosed with a defective immune system.
That's devastating.
It really is. People were subjected to immense anxiety, unnecessary lifelong treatments, and incredibly expensive antibody infusions. Thankfully, medical science is finally correcting this error. They are moving to a sophisticated new mathematical method called the polysaccharide responsiveness percentile, or PRP.
So instead of a hard pass-fail line, the PRP compares your individual response across multiple different cloak types against the percentile ranks of a completely healthy population. It's looking for a comprehensive pattern of response rather than just a single arbitrary number.
Exactly. It's incredible precision.
But taking a step back to the general population beyond getting the latest conjugate vaccines, how are we handling the day-to-day infection control?
It requires a strict dual approach. On the public health side, maintaining high vaccination coverage is the absolute gold standard because it sustains that vital herd protection, which actively suppresses the transmission of antibiotic-resistant strains. But on the clinical side, we have to enforce rigorous antibiotic stewardship.
And the sources are very clear on this. Healthcare providers do not, and absolutely should not, prescribe antibiotics simply because you were exposed to someone with pneumococcal disease.
No, never.
We can't use antibiotics as a preventative shield. If you take amoxicillin just because your coworker has pneumonia, you are just giving the bacteria in your own body free training to develop resistance. Standard respiratory hygiene, washing hands, covering coughs, improving indoor ventilation, and vaccines are the only preventative shields we actually need.
Perfectly said.
So what does this all mean for the global picture? Are we winning? I mean, there is undeniably good news. Between the year 2000 and 2015, global deaths from pneumococcal disease dropped by an astonishing 51%. We have conjugate vaccines integrated into 160 national immunization programs. But the pathogen hasn't surrendered.
No, it hasn't. We are winning major battles, but the landscape of the war is continually shifting. The massive problem we face right now is a phenomenon called serotype replacement.
It's essentially a high-stakes global game of whack-a-mole. We designed a brilliant vaccine like PCV13, and we successfully wipe out a hypervirulent strain like serotype 19A, but, nature abhors a vacuum.
Right.
When we clear 19A out of the nasopharynx, new non-vaccine types, or NVTs, rise up to take its place. Suddenly, cloak types that were historically rare and harmless, like serotype 8, 3, and 6C, are causing severe invasive disease.
And the surveillance data from Europe is a stark warning on this. The serotypes targeted by the newer PCV20 vaccine now account for about 60% of adult invasive pneumococcal disease there. And remember, the bacterium can undergo a process called capsular switching.
Which is swapping cloaks.
Yes, it can literally trade its genetic clone with a nearby bacteria to swap its sugar cloak and evade our current vaccines. We push them, and they immediately adapt.
It sounds like a game we fundamentally cannot win. Which brings us to the future. How does humanity ultimately win this arms race? Because if you keep swapping cloaks, we can't just keep playing whack-a-mole forever. We can't just make a PCV50 or a PCV100, can we?
We cannot, and you've hit on the exact biological limit of our current strategy. If we keep adding more and more sugar capsules to a single conjugate vaccine, we encounter a severe problem called carrier-induced epitope suppression.
Overcrowding.
Basically, yeah. It causes immune system overcrowding. There is only so much of that carrier protein you can inject before the T cells become overwhelmed and actually start competing with each other. The overall immune response actually weakens.
So if we were biologically maxed out on how much armor we can put on the wanted poster, what is the Holy Grail? How do we break the cycle?
The Holy Grail is a universal protein-based vaccine. Instead of trying to target the over 100 different sugar shells, which the bacteria can easily just swap out, scientists are looking beneath the cloak. They are utilizing advanced technologies like reverse vaccinology.
So instead of growing the bacteria in a petri dish and breaking it apart to see what it's made of, scientists analyze the entire DNA genome of the bacterium in a computer.
Precisely. They digitally scan the genetic code to find highly conserved surface proteins. They are looking for vital structural machinery that is shared by absolutely all strains of pneumococcus, regardless of what sugar cloak they happen to be wearing that day. They are looking for the biological Achilles heel.
What kind of proteins are they targeting?
Proteins like pneumolysin, which is the actual pore-forming toxin the bacteria uses to punch holes in our cells and destroy them, or choline-binding proteins like PSPA, which the bacteria absolutely relies on to stick to our lung tissues.
Oh, I see.
By isolating these shared proteins, sometimes packaging them in novel delivery systems like extracellular vesicles, a universal vaccine wouldn't care what serotype of cloak the bug is wearing today or tomorrow. It would recognize the core machinery of the assassin and neutralize it instantly.
That shifts the entire paradigm of how we fight infectious disease. It's moving from defense to proactive offense. As we wrap up this deep dive, I want to leave you with a thought to mull over. When we look at the history of Streptococcus pneumonia, we realize that our medical interventions, our powerful antibiotics, and our incredible conjugate vaccines aren't just fighting a static, unchanging disease. We are actively directing the real-time, real-world evolution of this ancient pathogen. We are participating in a microscopic chess match where every single move we make forces the bacteria to mutate, switch its capsule, and adapt to survive. The question isn't just whether we can invent a new drug, it's whether we can outthink an organism that has had millions of years to perfect the art of survival. Stay informed. Stay prepared. This has been Outbreak Brief.